Hey, and welcome back to the Docs Who Lift podcast. I'm your host, Dr. Spencer Nadolsky. Got my co-host, Dr. Karl Nadolsky Jr.,
Hey.
the great endocrinologist. We got another great endocrinologist with us today, Dr. Beverly Tchang. She is at Cornell, and you're associate professor? You're a big
I
wig over there.
just got promoted, actually.
Oh, congrats. Nice.
I'm now an associate
What
professor.
were you before? I always thought you were just
We'll go with that, Spencer.
okay.
That's-
Associate professor. She's awesome. She's an obesity specialist physician as well as an endocrinologist. And we have a lot of fun online talking on Twitter, now called X. And she recently did a post hoc analysis of something we've been talking about a lot recently. Basically, the history is that there are a lot of these menopause influencers out there trying to basically, instead of having a nuanced conversation, in the past, we've had a conversation with Dr. Jen Gunter about how the history of how everybody was kind of on menopausal hormonal therapy, then it went out of favor due to, unfortunately, the study that came out, what was it, the 90s?
Talking about the Women's Health Initiative that came out over 20 years ago.
Yeah, it was,
that suddenly scared everyone away
early
because
2000s. Yeah.
most of the people over 65 looked like they had increased cardiovascular risk and cancers. And then ultimately it taught us the timing hypothesis and a little bit more benefit. And
Which still needs to be
people
tested,
closer
by
to-
the way.
Yeah,
But
there's been a lot of
anyway.
studies supporting that now.
So anyway, the gist is that you should have a nuanced conversation. You shouldn't be blanketly telling people not to take it or to take it, but there are actually a lot of influencers now just basically telling all women who go through menopause everybody should be on these medicines no matter what. And one of the most recent things is that they're trying to promote the idea that menopausal hormonal therapy should be used for fat loss purposes, and which there was a retrospective analysis of those taking menopausal hormonal therapy and semaglutide last year. That's paper came out that suggested maybe there is some sort of benefit. Now, retrospective analyses can be highly confounded. What that means is that we don't actually have a known cause and effect from it. You need to do what's called a randomized controlled trial where you put one person on the experimental drug and then the other person on a placebo, and they don't know, and then see the differences then. So anyway, that's the story. We brought Dr. Chang on because she did a pretty cool analysis with tirzepatide specifically. And the reason we found this was because on Twitter, I was like, hey, can somebody contact either Novo Nordisk or Eli Lilly to see if we can get this data to see if they've broken it down between the different reproductive stages. And someone's like, didn't you see Beverly Chang's paper? And I was like, I think I actually did, but I forgot about it. So anyway, long introduction. Thanks for coming on, Dr. Chang.
Yeah, happy to. Thanks for the invitation. I think the crux of the question that you alluded to is really reflective of the lived experience of our female patients, where we get the sense that our weight is under control in our younger years. We go through perimenopause, things are kind of falling out of control, whether it's biologically, hormonally, or psychosocially. And then once you're in your 50s, 60s, it just feels harder to lose weight, right? We're doing the same things. You guys must hear this from your patients all the time. We're exercising, we're eating healthy, all of the right things. And even though it worked before when I was 20 years old, it's not working for us now. And so always the question is, what is happening hormonally from our 30s to 40s, 50s, 60s, and onwards that makes it so much harder to lose weight? And I think when we look at the landscape of weight management, of modern weight management now, where we're seeing these pharmacotherapies address a biological issue with weight, we ask ourselves, are these medications helping at all with this lived experience of difficulty losing weight through the different decades of a woman's life? And so that was the question we posed to all the industry professionals, right? Novo Nordisk and semaglutide included. And fortunately, Lilly picked up this question and decided, yeah, we should look at this in this secondary post hoc analysis. So to your point, Spencer, this is a retrospective observational analysis, meaning it doesn't answer the question of, does tirzepatide cause more or less weight loss in people with perimenopause or postmenopause or premenopause? It's really just a, a an exploration of like what happens. What happens to women on tirzepatide versus placebo in this randomized control trial? And did the reproductive stage seem to have any association? Right. So I think people need to always be cautious of that. And so, broad strokes, we looked at Surmount 1, 3, and 4, three randomized clinical trials. And those were chosen because they were specifically the people with obesity or overweight. We excluded Surmount 2, which was done in people with type 2 diabetes. So we wanted a semi cleaner or more uniform group of individuals, amounted to about 2,500 women. And then we categorize them based on their reproductive status. Now, in the clinical trial protocols, they don't explicitly ask, are you in premenopause, postmenopause, perimenopause? But they are required to figure out what the reproductive status is because they have to provide reproduction counseling, right? They have to be told, oh, if you're sexually active, you need to be on birth control or what have you. And so a lot of that data was captured in some shape or form. And because these women are followed up with their primary care doctors as well, et cetera, then we do have some biochemical data just from their follow-ups with annual OBGYN like routine visits, And so the way we categorize them, I think, is easier if you just think of pre and post. Pre is like less than 40 years old, no other signs or symptoms that have been captured in the chart notes. And then post was greater than 55 as a sort of big bucket. And then those who are also older than 40 with like an elevated FSH or chart note indicating menopause, chart note indicating um, maybe a oophorectomy or something like that, like surgical menopause. And then the squishiest group is like that perimenopause group, right? We know this in clinical practice too. There's a whole list of criteria I won't get into here, but it was, that 40 to 55 age range, maybe an elevated FSH, but not so high that we would say that it's completely close to menopause. And I think the hardest part that that to discern here was that hormone replacement effect. And I can tell you from the design perspective, we went back and forth a lot because the hormone replacement therapy, when you look at it from clinical practice, sometimes we call it hormone replacement therapy, sometimes it's birth control, right? Because the people on hormone replacement is that perimenopausal group where they are age 40, 41. Theoretically, maybe they could still get pregnant, right? They're still having some periods. And we as clinicians are making a decision whether, okay, let's keep you on your combination oral contraceptive, or should we switch you to hormone replacement levels of perimenopause? And so when you look at the tables, you'll see a percentage of individuals who are on HRTC, which was really hormone replacement therapy or contraception. We really couldn't tell what they were on. So I think that's like a huge confounding factor. But and there was back and forth discussion of like, should we just remove those women and make it a very clean set? But we decided, once you start removing data points, then you're losing out on the whole purpose of the question, which is just exploring what's happening here. So we kept them in, we put all the data in there. And by and large, when we did the whole post hoc analyses for SURMOUNT 1, 3, and 4, we found that there was no significant difference in the weight loss achieved between those three groups. Because that wasn't quite the question, or like the way that the studies were powered, the conclusions we could only draw was that, all right, tirzepatide is still better than placebo. And it's still better than placebo by this 15-ish% weight, or sorry, 20-ish% weight loss compared to placebo in these three groups. And it doesn't seem that the reproductive status modified the weight loss effect.
Nor did the hormone therapy or contraceptive therapy or anything like that. There was no signal suggesting that that made any major difference, right?
There was no signal, but we acknowledged that the numbers were small and we couldn't really, again, discern was it hormone replacement therapy or contraception. So we didn't actually write any narrative around that.
So you're being scientific about it.
Being very
Which
cautious. Yeah.
which nobody wants to hear nuance. Nobody wants to hear subtleties. They want to hear, oh my God, everyone has to be on these things and combination therapy and everything like that. That's why they get the traction and online.
I mean, I think that if you want to pull one big takeaway is that the medication works. The medication works for weight loss, for reducing that waist to height ratio that we examined too, um, regardless of your reproductive stage.
Yeah. But what these people out there online, they're trying to convince everyone based upon some of these. Some of it's based upon, physiologic data we understand a little bit, that some of the mechanistic stuff saying, oh, the females all have to be on menopausal hormone therapy in addition to GLP to get the most optimal benefits. So where does that come from? So we were just talking before we got online that there are a couple reviews just in 2025 in the Journal of Endocrinology, February of 2025. If anybody's interested to nerd out that much, it goes through some of the rationale. Why could this be a thing? And it talks about estrogen playing some role in reducing, food intake by enhancing the sensitivity of the female areas of the brain to the anorexigenic factors such as leptin, for instance. It gets into, talks about some of the preclinical data in rats, but humans are not rats. Female rats seem to be more responsive to GLP. And then, and see what you think of this, just in a lot of the trials of the GLP therapies, specifically like in the STEP trials, it seemed like there was a greater percentage of weight loss in females than men. And most of those females in those studies are premenopausal, unless I'm mistaken. I'm pretty confident in that. But they're also usually have larger proportions of women too. And so there was some of that to kind of, back up, well, oh, they do better, than men. And then, obviously we know a little bit of the menopausal transition tends to come along with some weight gain and some weight distribution changes through menopause. And so then they put that all together and say, oh, this is the case. I will say that there's a systematic review meta-analysis of all the trials showing that the cardiovascular, cardiorenal benefits of these drugs had no difference in sex. And that's like kind of across all ages. That was in JAMA just recently, but so
What do you think?
yada yada yada. Yeah.
What do you think? I mean, I have some other thoughts, but I want to.
Yeah, I think that the wellness industry likes to make broad strokes, right? That's more of marketing claims than anything else. And the challenge is always that there's always like a tiny bit of truth to all of their marketing
Yeah.
claims, which is always the problem. You take them, you just like explode into something that's like, wait, how did you get from point A to point Z? It's just it's wild. But when you refocus on point A, yes, estrogen has been shown to be an anorexigenic hormone in the brain of mice and rats, like directly on the rats hypothalamus, where your anorexigenic POMC neurons are active. So estrogen activates POMC neurons in rat brains. Can we extrapolate that to humans? I don't know. We do that a lot for so many other things. And it's such a compelling story that a lot of people like to hold on to that. And then when you combine that with the actual physiologic observational data we have from the study of women's health across the nation, the SWAN study, you do find that, yes, we see weight gain across perimenopause. That weight gain, though, doesn't seem to be due to the perimenopause itself. It's really just from aging. Because when we look at that weight gain, we see the slope upward, but it doesn't become steeper around perimenopause. It's just the same. What they did, though, when they looked at body composition, it was that the fat accumulation becomes a little bit steeper. Lean mass, also reduction, a little bit steeper too. And so that's the body composition changes that you mentioned, Carl, and then I think a lot of our female patients experience too. So it is, um, it's so, uh, I guess it's so, I forget, I'm losing the word, but it's tempting, right? To say, okay, if estrogen is the characteristic uh, and defining hormone, loss thereof, of perimenopause, and we see these body composition changes, can we just replace it and reverse all of that? And to your point, so many observationals, usually they're observational studies conducted on randomized control trials, right? When they look at those body composition changes, they also find a statistically significant difference in fat mass changes. Like you're protected by about 1 pound of gain, of fat mass gain, if you're on hormone replacement therapy.
Yeah.
And that's that little grain of truth that I think wellness industry likes to pull on, where in reality, it's like, is that really clinically significant? I don't think so. But that's the data we have.
Yeah. So I know what I say to patients in this because you and I probably see a lot of perimenopausal patients. I think Spencer does too, just based on the nature,
All
because a lot of in the 40s and 50s and yeah, they always want to talk about the weight. And so I just kind of remember going all the way back to fellowship when we were in fellowship and studying all this stuff. And it seems to be like you just said, a very subtle trend of people who are on menopausal hormone therapy tend to have a little bit less weight gain and a little bit better body composition, but not in such a substantial degree that it's really, really meaningful. And there's so many other factors to that, because if they're having vasomotor menopausal symptoms, that that causes a lot of other problems. I mean, when people feel better, they tend to do better with their diet and exercise and all that stuff too, and just everything's better in life. So there's so many confounding factors with this stuff, and it's important for people who need it. Yes, we females
You,
should be
you
on it.
could probably pull up that semaglutide MHT retrospective study, because that's what people are starting to point to, is that looks like people on the MHT and semaglutide did better. And what I would just caution to say, like, if women are seeking out the MHT, this
Mhm.
is why retrospective designs are very difficult. If they're seeking it out, they may be more in tune with their health compared to someone that doesn't get it. Or they may have better care. They may have a better doctor. I don't know.
So, well, what you're saying is there's a very high likelihood of a selection bias.
Selection
That's
bias.
what you're
So
saying.
someone that goes on MHT, those types of people may be more in tune, may be more geared towards improving their health. It's hard. It's just hard to know.
Mhm.
So I would propose, before I make any claims, no, it doesn't have any difference, or yes, there's clearly a difference. I think there's a suggestion in some of the literature, although Dr. Chang's post hoc analysis doesn't show it. But as she said, there um, are some drawbacks to the study and things that they just can't say for sure. I think you need to do a randomized trial. I know they're trying to do this estrogen GLP-1 conjugate type of drug, where they think it might help target the liver fat and all these different things. But these menopause influencers are just basically telling everybody they need to be on it regardless of vasomotor symptoms or anything else for body composition reasons. And I would ask you, both of you, I mean, I do this all day, and I have patients that are struggling with their weight. I start them on the medicine. I don't I don't see, and I do a lot of MHT. I don't see any strong difference, especially if they're at a plateau. The MHT doesn't make them all of a sudden melt fat off their body. It makes them feel better. Now they're lifting weights and doing stuff and be
Yeah.
able to, like, sleep, which can then eventually start changing body composition. But it's not some miracle thing where, like, oh, the tirzepatide or semaglutide's working all of a sudden. Again, anecdotal case, like, we can't
No,
just.
yeah. I mean, I would think you're right. There's no data to support that, and Dr. Chang's paper is really probably the best we have to
I
say,
think so.
the bottom lines are we know that these medications work for whom they're indicated. They're very, very good therapies for all people of adults through perimenopause to menopause. They have good clinical health outcomes, which are the most important things we care about. And in those perimenopausal and menopausal females who have symptoms and indications for menopausal hormone therapy, they're generally very good too. And that's a personalized decision, risk benefit thing to have. And that's kind of where it stands and how it always should be. What do you think?
What are your thoughts,
Yeah,
Dr. Chang?
I'll add to that with the retrospective study, right? If you think about the patient in front of you, the person who's on menopausal hormone therapy sought that out, probably very well educated, especially given how far the pendulum has swung back and forth
Mhm.
between Women's Health Initiative and today's wellness industry. Probably very well educated, had a degree of hot flashes or some quality of life enough for her doctor to start the menopausal hormone therapy. The person who's not on menopausal hormone therapy could actually still be someone dealing with significant hot flashes or anxiety, emotional changes, what have you, and may actually end up on medications that cause weight gain.
Oh, that's a great point.
Forget, right? That
Oh, yeah.
parox-
Right there.
paroxetine.
Yeah.
Paroxetine is our non-hormonal option that is FDA approved to treat hot flashes. It is a huge culprit for weight gain.
There you
So
go.
That's an
there's
amazing point.
confounding
Look at that.
factors there. And
And the
then
insurance companies always tell us to use that if people can't be on menopausal hormone therapy, by the way, and we have these these newer medications that are
the
not good, not
Fazolitant.
yeah. So I use a lot of that. It's brand name Veoza, and then
I try to get it through it. Don't get it through insurance.
2/3 of the time, I mean, luckily some of my patients are able to get the coupon and all that stuff, but 2/3 of the time the insurance comes back and says, no, they got to be on Paxil, which is what you're talking about, paroxetine, which is one of the most
Paxil
notorious
worked.
weight gaining, influencing antidepressant meds that just happens to help with hot flashes. That's an amazing point.
Good.
And it's not even about, maybe you're not even treating hot flashes, but so many of these women are dealing with emotional changes, right?
Other
Social changes. So they come in with new depression and new anxiety, and their PCP, bless their heart, starts them on an SSRI, right? That SSRI could also be causing weight gain in of itself, when really it's just the estrogen hormonal fluctuations. Now,
Right.
hormone replacement therapy is not on label to treat anxiety or depression, of course, but I've seen enough women in this transition period that it's the fluctuations from estrogen that's causing them to feel crazy, so to speak. And I think
Sorry, you
I'm
get
up here
sleep and stuff too, like
sleep,
people are
all of
having
this.
these sleep disturbances. Oh my God, they feel so much better.
Yeah, and when they're not sleeping well, what do? They go over and they buy an over-the-counter Benadryl,
Mm.
and then that can also cause weight gain.
There you go.
So I think there's so many pieces that we're not capturing because we don't know what the patient experiences and how much women in perimenopause, how much they do to mitigate their own symptoms without seeking professional help. Because one, they think they have to do it all on their own, and women are amazing. And number two, classically, the medical community hasn't been that helpful to women in perimenopause. So I think there's a lot retrospective observational studies don't capture, of course.
So if you haven't listened to our Jen Gunter, she goes over the Women's Health Initiative and all the issues from there and the timing hypothesis, and we kind of had that discussion. Go listen to that podcast. But moving forward, I think it would be a great, I don't know if you want to do it, Dr. Bev, but a randomized controlled trial. I think it would be I think it would be good to do. Why not?
We'll help you design it. Just put us on the paper.
Yes.
With medication.
Yeah, I think we should have
With
one that design.
medications, with like semaglutide and tirzepatide. You laugh, but I always bring this point back that, to your point, Karl, the baseline characteristics are these women. 100%,
Yeah.
50% of the population in these studies are age 46, 47, 51, 70, 60 to 80% women.
Yeah.
So when you think about who are these medications intended for, it is perimenopausal women.
And women in
The
general,
safety support.
semaglutide, tirzepatide, retatrutide, which isn't out yet. It seems to be that women do better on these. So
Yeah.
thank goodness that instead of the husband that stops eating a couple French fries who loses 10 pounds, and the woman who cuts out everything and basically eats salad and only loses a pound and gets frustrated at the husband. Thank goodness that that they do respond very well to this. I think in the meantime, though, like, we should be cognizant of perimenopause, menopause. I'm just I see it all day. I see it all day long.
Yeah.
And they've, like you said, they've been thrown on SSRIs, and it just doesn't really help. So you use them as indicated. I'm not going to tell you they're going to help you melt your fat off, but they may help you do the habits that help with the weight loss. They may make you feel better. Does that sound reasonable?
100% holistic approach
Yeah.
is always the answer, I think.
Yeah.
Very good. Thanks so much for coming out. We're going to put your study in the show links. Anywhere people can find you? I know you're on X. Anywhere else?
I'm on X. I'm on LinkedIn. I have a website, beverlytchangmd.com. So you can find me
Perfect.
at all of those places.
You're amazing. You also did a birth control review, I swear, or you did it at least on X. I thought it was great. So maybe we're going to have you on again. We'll talk about the differences in birth control and weight gain.
Oh yeah,
and all
that was
stuff.
interesting and fun.
Oh, this.
Yeah.
See, look at you. We're gonna-
Nothing official, but yeah, it was definitely a
It was a good
mini
review.
dive in a thread that I posted up
okay.
on Twitter a while ago.
I love that. Thank you so much. Share this with anybody who's, probably seen some of these menopausal influencers. Again, we want the elephant in his room that my brother and I, we will never menstruate and never go through menopause. So we prefer to talk to women, because otherwise they're like, you guys don't know a damn thing. Like, okay, I don't want to be the one.
Meatheads who don't menstruate. All right.
Meatheads
No.
that do not menstruate.
That's your new
That's
title.
New
for your
website.
podcast.
Yep. All right.
New website.
Thanks so much for coming on, Dr. Chang.
You're awesome.
Here's our outro.
Yes, they do. Thank you.